Thank you very much. Good morning, everyone. And I'd like to thank the organization committee and the society for inviting me for this presentation. So we are going to go through the news of cardiopulmonary resuscitation research for the last years. So first, we have to acknowledge that the cardiac arrest registry are becoming very important in the research about cardiac arrest. And for the first time, we have a registry with more than 1 million patients included. This is a cardiac arrest registry from Japan. And in this study, they look at the impact of public access defibrillation in Japan. With this registry, we are also getting some trouble with a variation in outcome inside the registry and inside the same country or inside the country in Europe. We are going to see that. So there are huge variation in survival. And the same thing in Europe from that study. We can see that there is huge variation also. So it's difficult to imagine that such variation are only from the process of care, and it's probably also a problem of the way that data are collected, and we have to be careful when we look at data for that and about this variation. One important point of the guideline is the community response, and to show that community response can save lives. And there is an important role of the dispatcher of EMS services. They have to recognize cardiac arrest, and we know sometimes it's difficult. They have to give advice for cardiopulmonary resuscitation on scene, for bystander cardiopulmonary resuscitation, and they have to dispatch as soon as possible an AED and an emergency team on scene. For that, we can have some help of technology. And this is a statement of the American Heart Association with the use of mobile device, social media, and crowdsourcing to help improving emergency cardiovascular care. And this is an example of technology. This is an application widely implemented in the US. So with that application, you get a text with the location of a cardiac arrest, and you can say the volunteer with the application to the location of the cardiac arrest to start CPR before EMS arrival. We just received some funding from the French Health Ministry to start a study with that device in France. 12 SAMU are going to participate with 2,000 patients to include that study. Of course, CPR quality still matters. It's still a very important point. And in this study, where the depth was adjusted, we can see the importance of the chest compression rate. For the reference group, which was between 100 and 120 compression per minute, you can see that if you go below that compression rate, the odds ratio for survival is dropping quite a lot, 0.63. And if you are over 120 compression per minute, it's the same, odds ratio drop very quickly. So we have to stay on the target between 100 and 120. Another important point, and I think Jeff Perkins is going to talk about that after, is that mechanical chest compression is also an important question about cardiopulmonary resuscitation. And as you can see in this meta-analysis, there is no benefit from randomized controlled trial for mechanical CPR for all patients. There are some evidence from observational study, but it's a low-quality evidence about that. And in the guideline, it is not recommended to use mechanical CPR for all patients, especially during the first minute of CPR. And mechanical CPR can be useful in specific settings where the delivery of high-quality manual compression may be challenging or dangerous for prolonged CPR, for example, or in moving vehicles. Let's talk about drugs now. So you all know that epinephrine is probably bad for the neurologic outcome in cardiac arrest. And in this study, they look at the administration of epinephrine for cardiac arrest with initial shockable rhythm in hospital. And what they found is that after the first defibrillation, a lot of patients are receiving epinephrine within the first 2 minutes. It's more than half of the patient. This is contrary to the guideline. You know, in the guideline, you have to wait for free defibrillation to use epinephrine in shockable rhythm. So half of the patients are getting epinephrine before that time point. And as you see, it's very bad for outcome. It's bad for risk. It's bad for survival. It's bad for good neurological function. So be careful with epinephrine. You should use it, at least for initial shockable rhythm, for after free defibrillation and not before. So early administration, contrary to guideline, was common in that study, more than 50% of patients, and associated with a decreased chance of good outcomes. Another drugs and another study from this year, which was Amiodarone, Lidocaine, or Placebo for out-of-hospital cardiac arrest. And the primary outcome was not significant for Amiodarone versus placebo or Lidocaine versus placebo. The primary outcome was survival to discharge. It can be interesting to look at more practical endpoint for a drug where the goal of this drug is to stop a refractory VF. And when you look at risk or patient admitted to the hospital, it was significant for Amiodarone or Lidocaine. You can see that. So that's remain a question if we should use it, and it's probably a discussion for the next guideline. I'm going to talk of reperfusion injury protection now, because there are several studies this year that look at that reperfusion injury protection strategy during CPR or just after CPR. The first one is with the use of therapeutic hypothermia during out-of-hospital cardiac arrest using rapid infusion of cold saline. It's something we tried a few years ago. And in this larger study from Australia, they found no benefit to the use of rapid infusion of cold saline during out-hospital cardiac arrest. So you can see for all rhythms, there is no difference. For shockable rhythm, it was even lower. And one important point is that the risk for shockable rhythm was lower with the use of rapid infusion of cold saline. So no benefit, and we should not use rapid infusion of cold saline during CPR for reduction of therapeutic hypothermia. Another study, this was post-ROTS, so maybe it will be talk for next speaker. It was a study from Alain Cariou and one of the moderators of the session. It was the use of erythropoietin after out-of-hospital cardiac arrest. And again, no benefit in survival. And there was a higher rate of thrombotic complication with the use of erythropoietin. So no benefit. Another study with a cyclosporine in non-shockable rhythm from Laurent Argot and our other moderator. And again, no benefit in SOFA score with the use of cyclosporine during CPR for out-of-hospital cardiac arrest. The only study with a benefit for reperfusion injury protection was the Xenon. It was a preliminary study with an endpoint about MRI, and they found on MRI a limitation of cerebral to white matter damage, and they are now conducting a study with clinical endpoint to see if that could be beneficial for patients. A few studies about experimental research from this year also. So one question that was raised is the position of CPR during mechanical compression. It was from an idea from Korea where they are troubled to transport patients to the hospital with an elevator. So they ask the question, so whether or not it's better to put the patient head down or head up. And you can see the effect of head on, so that was, sorry. So this is the aortic pressure. So no change in aortic pressure when you go head down. the ICP goes up when you put the patient head down during CPR, and therefore the calculated cerebral perfusion pressure goes down. You have the exact opposite effect when you put the patient head up with a good quality CPR. The ICP goes down and the cerebral perfusion pressure goes up. We showed that the brain blood flow, it was calculated, it was measured with a radioactive microsphere. Depends on head position, and you can see when you put the head up, you have a better flow to the brain in the left hemisphere, right hemisphere, and in the brainstem. So in a recent study, the previous study was performed with the full body tilt. So they tried to look at just head and thorax elevation, not a full body tilt. So it was a study with 8 minutes of VF, conventional CPR for 2 minutes, and then randomization between those two positions. It was published in Resuscitation. And you can see with 20 minutes of CPR, so a prolonged CPR, the cerebral perfusion pressure remains high with the use of ICD, ITD, and head up, and goes down with a flat position. Same result on a human cadaver study, with the intracranial pressure goes down. Also, it was a special preparation of cadaver with fresh cadaver, and there is a preliminary result from one experience in Florida where they tried to implement that in human. So they added Lucas plus ITD and head up, and they showed an improvement in hospital admission survival after this implementation. Another drug that can be a good target for decreasing reperfusion injury and improving perfusion, because we have both effects. It's sodium nitroprusside because it's a arterial vasodilator, and it has an NO effect, and with vasodilation you can improve brain flow if you can maintain a good quality of CPR and a good perfusion of the heart during CPR. So this was a paper published also this year. They performed 45 minutes of CPR. It was a model with a coronary occlusion. So 45 minutes of CPR with either a snappy eCPR or standard ALS. The endpoint was at 4-hour survival. You have the lactate acid during the time course of CPR, so it was better in the snappy CPR group, and survival was better with the snappy CPR animal also after 4 hours than in the control animals. So as a conclusion, so it was a quick review of the literature of cardiac arrest from the last 2 years. Technology will probably help improving cardiac arrest outcome. We can see that some application to dispatch a bystander on scene can be probably helpful to improve bystander CPR. We have to prove that it can improve survival also. There is no silver bullet for reperfusion injury protection right now. Maybe the combination of several therapies could be helpful. I don't think we should sweep all treatment under the carpet yet. We should probably wait some more data and the result of the next guideline. For Amiodarone, I'm sure therapeutic hypothermia is going to be about after this talk. And we have some new insight in the physiology of cardiopulmonary resuscitation that could lead some interesting results in the future. So thank you for your attention.